Good evening. I am Dr. Vivian Jolly B., breast surgical oncologist at New York Presbyterian Brooklyn Methodist Hospital, and assistant professor of surgery at New York Presbyterian Weill Cornell Medicine. And I'm joined by my colleague and co-course director, Dr. Kamel Abu Hussein, who is a medical oncologist practicing at MD Anderson Cancer Center at Cooper. We want to take the time to thank you so much for joining us for our second annual event, The Road to Breast Health Equity in the Era of COVID-19. We have a phenomenal lineup of speakers, and when I say phenomenal, I mean phenomenal. So we encourage you to go on social media platforms and hashtag us at hashtag BHE 2021, that's Breast Health Equity 2021, so that your friends and colleagues are aware that we are having such a dynamic symposium. Also, please see a attachment in the chat box. It will include important information like the CME information disclosure statement, and that's going to be disclosures for all of our presenters. And it is with great honor that I introduce our very first speaker, Dr. Lisa Newman. Dr. Newman is a world-renowned breast surgical oncologist with a practice dedicated to breast cancer management. She actually was appointed to oversee the breast program for Weill Cornell Medicine at New York Presbyterian Hospital Network, and that serves Manhattan, Queens, and Brooklyn. She is also the founding medical director for the International Center for the Study of Breast Cancer Subtypes, which became headquartered at Weill Cornell Medicine with Dr. Newman's recruitment. Dr. Newman's primary research is focused on ethnicity-related variation in breast cancer risk and outcome, the evaluation and management of high-risk patients. Her extensive research related to disparities in breast cancer risk and outcomes have been published in numerous peer-reviewed medical journals, and she was featured in CNN's documentary Black in America Too. She also has been the featured breast cancer medical expert for NBC Today News, as well as CBS Nightly News, and it can go on and on and on and on. So without further ado, let me welcome to the stage the first, the fabulous, the originator, Dr. Lisa Newman.
Oh, fabulous, Dr. B. I just love you.
I got you.
Anyway, it is such a pleasure to join everybody today, and congratulations to you guys for putting together yet another awesome conference, so important in educating all of us about breast health awareness, which has heightened significance in addressing the disparate burden of breast cancer on communities of color now in the wake of the COVID pandemic. So thank you for what you're doing. So I am going to try to go to the share screen function. And I was asked to discuss with you guys today the topic of moving toward breast health equity in clinical trials. And I can't help but put in a plug for this manuscript that was just recently published that I had the distinct honor of being able to work on with several of my bonus daughters, Dr. B, Dr. Taiwo, and Dr. Balogan, where we talked about the history of breast cancer clinical trials and the issue of disparities and how to understand breast cancer disparities better through information available in clinical trials. So some of the concepts that I'll be discussing in this presentation come from the manuscript that we worked on together. So I thank all of my colleagues for their wonderful work on this project. Now, all of you that are in this viewing audience are no doubt already familiar with the different types of clinical trials, clinical research studies that are available in cancer, some being observational studies, some being formal clinical trials of the phase 1, phase 2, and phase 3 categories. Most of the clinical trials that I will be discussing in this presentation will be the discussion of phase 3 clinical trials, the prospective randomized clinical research in cancer. But for all of you out there who represent the advocacy and the patient community, I do want to emphasize right off the bat that contributing to our body of knowledge in terms of improving cancer care, and in particular breast cancer care in the future, doesn't necessarily mean that you have to be participating in a clinical trial that involves your treatment. And we learn a tremendous amount about cancer biology and certainly breast cancer biology through studying biorepository information. So if you have a diagnosis of breast cancer, or if you want to serve as a control, a healthy comparison patient in a breast cancer study, please ask your physician about opportunities to contribute through biorepository information. Tremendous way to contribute. And my colleague, Dr. Melissa Davis, is going to be talking in this very same session about her fascinating work looking at the genetics of breast cancer and how that impacts on breast cancer disparities. A lot of Melissa's work is a perfect example of how you can make a contribution to clinical research in breast cancer without necessarily being a part of a treatment trial. Now, cancer clinical trials are indeed important because they really are the optimal established mechanism for safely improving our standard of cancer treatment compared to the older patterns of treatment. A clinical trial should be an optimal strategy for disentangling the confounding effects of racial ethnic identity versus geographically defined ancestral hereditary factors versus socioeconomic status on cancer burden. Clinical trial participation should also offer racial ethnic minorities protection from discriminatory practices and biases in the delivery of care, because the clinical trials mechanism is extremely tightly regulated today. And there are a number of policies and rules that really should be protecting patients from biases related to delivery of care. And every aspect of the clinical trial participants' management should be set up and standardized by that clinical trials mechanism. Clinical trials do, however, have many challenges and potential pitfalls in trying to realize their promise for being the best way to improve outcomes from cancer by improving the standard of care. The quality of the clinical trial results depend completely on the study design and how it's implemented. The trial must have representative accrual representing the general population of cancer patients. The trial needs to be accessible to all communities in order to have that representative accrual. The trial must not only be accessible, but it has to offer a therapy that is going to be affordable to our cancer patient population. And again, I cannot emphasize it strongly or often enough. Trials results cannot be generalized to the entire population unless the trial participants reflect the socioeconomic, genetic, and cultural features of that general population. Now, the data on this table come from a study that was published several years ago by a wonderful African-American and brilliant surgical oncologist, Dr. John Stewart. And in this study, John looked at the participants on a series of NCI breast cancer clinical trials, and he compared the number of patients on that clinical trial stratified by racial ethnic identity to the number of overall cancer patients with that diagnosis belonging to that racial ethnic group. And from those numbers, John calculated an enrollment fraction. So what you see here painfully is that it's actually a relatively low enrollment fraction for women of all racial ethnic backgrounds that participate on breast cancer clinical trials. But those enrollment fractions are particularly low when it comes to our communities of color. And African Americans, Hispanic Latino Americans, Asian Pacific Islanders, American Indians, and Alaskan neighbors were all less likely to be participants on clinical trials compared to white American breast cancer patients. Fast forwarding to some investigators that have looked at these types of data in more recent studies, we see that the pattern of underrepresentation of racial ethnic minorities, and in particular African Americans, persists over time. The data shown by these bar graphs come from clinicaltrials.gov, which is a publicly available website that reports on the availability and eligibility criteria for a whole variety of different clinical trials, observational studies, cohort studies, treatment trials. And in this particular study published by Dumas et al., they looked at more than 1,000 clinical trials for cancers of a variety of different types, but these were all phase 3 cancer clinical trials, prospective randomized studies. And it was very disappointing to see that only a little less than a third of those trials actually had enrollment information available stratified by racial ethnic background. And so the majority of these studies did not even track the distribution of their patient participants. Of the studies that had racial ethnic identity information available, only 6% of the African American patients were enrolled in clinical trials. And when you looked at breast cancer clinical trials, they did a little bit better with just over 7% African American enrollment in these clinical trials. But that is still underrepresentation compared to the 13% representation of African Americans in the overall American population. And it's very disappointing participation when we consider the fact that African Americans suffer disproportionately from the mortality burden of breast cancer. So we really need to be represented appropriately in these studies so that we can learn more about how to better treat the disease in our own patient population. In yet another even more recent study, Gopichetti et al. Also used the clinicaltrials.gov website, and they looked at studies over a range going to even more recent years up to 2019, and they compared clinical trial demographics for 20 colon cancer studies and 74 breast cancer studies, and they still found very few studies even reporting on the racial ethnic distribution of their study participants. Of the 74 breast cancer studies reported, we saw dismally low participation of African Americans accrued at fewer than 4% of the participants being African American. The data shown on these graphics come from studies looking at FDA approvals for different drugs in cancer, and looking at these trials and the information submitted to the FDA to evaluate these novel drugs for cancer treatment. And in this study also, it was demonstrated that not all companies are even reporting on the racial ethnic distribution of the patients participating in the studies to evaluate these novel therapeutics. And the numbers became even more disappointing if you looked at the trials submitting information for FDA approval of these novel therapeutics, if you looked at the number of studies that did subgroup analyses based upon racial ethnic identity. And so we really are handicapped in understanding the role of race ethnicity in clinical trials and in cancer outcomes, because a lot of these studies are simply not even reporting on the features of the patients that do participate in the studies. Now, of the studies that are available, as we noted, we do see relatively low participation of African Americans and other communities of color. And the explanations for this underrepresentation are varied, and they can be ascribed to a number of different levels of barriers. Provider level issues with providers simply not being comfortable discussing clinical trials with their diverse patient population, which is just heartbreaking to think about, but it is a reality. There are some clinical trial providers who simply feel that they are going to alienate their patients, and in particular, they are fearful of alienating their patients of color if they bring up clinical trial participation. And we also have a huge problem in terms of the inadequate diversity of our healthcare workforce, and in particular, our clinical trialist workforce. I think that we are automatically handicapped if we have a healthcare workforce that does not reflect our communities, our patient populations, and that generates a lack of trust in that healthcare workforce. It generates less trust for the clinical trialists when the patients do not see a workforce that reflects their own families, their neighborhoods, their communities. There are patient-level issues with fear and mistrust of the healthcare system, and these fears will be compounded when it comes to clinical trial discussions. And then there are systems-level issues where the media is not necessarily providing uniformly positive or appropriate messages regarding clinical trial participations. There are issues with clinical trials not being broadly or appropriately available to all members of our patient population based upon socioeconomic status. There are disparities in availability of clinical trials in different types of hospitals. And our clinical trial designs are often flawed in terms of being able to recruit diverse patients. We all have to assume some responsibility for inadequate communication with our patients when it comes to low accrual of patients of color in clinical trials. And many clinical trial potential candidates express the fact that clinical trials are simply not offered to them, and that's the reason why they were not, they did not have an opportunity to accept or decline. But of the patients that do participate in clinical trials, by and large, they express satisfaction with that experience in survey studies. This study provides an example of some of the heartbreaking results that we see when we evaluate critically our clinical trial workforce. And this study was published very recently, just last year, in Cancer. And in this study, nearly 100 members of the clinical trials workforce from 5 different large cancer centers were surveyed to ask the workforce members about their views on recruiting diverse patients to clinical trials. And the heartbreaking aspect was that many of these respondents stated that they simply did not view racial and ethnic minorities as being appropriate or adequate clinical trial participants. And they frankly stated that they sometimes withheld clinical trial opportunities from minorities because of those perceptions. So a lot of work that we have to do in making sure that our clinical trial colleagues address clinical trial opportunities with their patients appropriately. This study is an example of communication issues as well. The renowned communications expert, Terry Albrecht, viewed videotaped clinic visits between oncologists and cancer patients. And what they found in these viewed recordings of those visits was that the oncologists spent much more time with their white cancer patients compared to their Black cancer patients. And this disparity held true when it came to the discussion of clinical trials. Less time spent discussing clinical trials with the Black cancer patients compared to the time spent with the white cancer patients. And it will come as no surprise to all of you in this viewing audience that the legacy of research atrocities such as the Tuskegee study and the Henrietta Lacks story, we are still dealing with the consequences of these atrocities, with many patients being fearful that they will be treated as guinea pigs if they participate in clinical research. The Tuskegee study, of course, was horrific in the fact that it was a study set up to determine whether or not African-American men had a different experience with the disease of syphilis. And even after penicillin became widely available as effective treatment for syphilis, the men in the Tuskegee study, these African-American men, were left untreated for their disease. And it took many years for the study to be closed before this was widely publicized at how horrifically these clinical trial participants were being treated. And it wasn't until 1997 that that a presidential apology was formally given by President Clinton. The global effects of Tuskegee live with us today. Tuskegee is not only detrimental to our ability to accrue patients onto cancer clinical trials, but the global effects can be seen in terms of mistrust for the larger physician community, mistrust of scientists overall, and mistrust and fear of overall medical treatment, even outside of a cancer diagnosis. And it impacts patients of all ethnic background. In a fascinating mail and telephone survey study by Shavers et al., it became apparent that more than a third of African American and white American respondents stated that they were aware of the Tuskegee story and that the Tuskegee story was a factor that would influence whether or not they participated in a clinical trial. Other investigators, such as Lucille Adams Campbell when she was at Howard University and Mike Simon at the Karmanos Cancer Institute, have demonstrated that there are inherent eligibility barriers for African Americans participating in clinical trials because many of these studies have comorbidities as exclusion criteria. And comorbidities such as hypertension and diabetes are more prominent in the African American community. And one of the biggest issues is clinicians failing to offer a clinical trial. Nonetheless, despite all of these issues, we have learned a number of important messages from the breast cancer clinical trials that have been conducted thus far. This was a landmark study published by Kathy Albane et al., where Kathy looked at a whole series of Southwest Oncology Group adjuvant therapy trials for a variety of different cancers. And she wanted to determine if the outcomes from clinical trials would show that equal treatments resulted in equal outcomes regardless of racial ethnic identity. And happily, that was the case, showing that appropriate standardized treatment through the clinical trials mechanism can mitigate some disparities in outcome, but a couple of exceptions became apparent. For the African Americans on clinical trials for hormonally driven cancers, such as breast cancer and prostate cancer, we continue to see a significantly higher recurrence and mortality hazard, suggesting that for some cancers, racial ethnic identity does still make a difference. It was very disappointing when Kathy's study was published that her study was cited as an example of racial profiling in medical research. And it was disappointing because, of course, the concept of racial profiling is something that needs to be condemned when we talk about the criminal justice system. But in medical research, we have to evaluate all of the characteristics of our patients to try to figure out why some patients do better than others and try to figure out when tumor biology does vary in the alignment with racial ethnic identity. The Women's Health Initiative was a very powerful prospective randomized series of clinical trials that did show an example of how racial ethnic identity is linked to tumor biology. For the more than 150,000 women on the Women's Health Initiative studies, it was found that in following these women prospectively, the African American patients on this study were 4 times as likely to get estrogen receptor negative cancers compared to white American women. We've also learned about disparities in looking at chemoprevention trials. This is an important area to evaluate because tamoxifen, one of our most widely available chemoprevention medications, it's the only chemoprevention that is approved for premenopausal patients. And we know that African American women are more likely to get breast cancer at younger ages. But tamoxifen is associated with VTE risk, and the risk of thromboembolic phenomena is higher in the African American community. Tamoxifen will only prevent ER-positive breast cancers, and African Americans are more likely to have ER-negative disease. Unfortunately, however, we couldn't say a whole lot about African Americans and chemo prevention with tamoxifen based upon the NSABP P01 trial, because fewer than 2% of the study participants were African American. The chemo prevention trial that was first utilized, the P1 study comparing tamoxifen to a placebo in high-risk women, relied upon the Gale model for estimating risk and determining eligibility. And from this study, from this slide, we see that the Gale model at the time that it was being used for the P1 study tended to underestimate breast cancer risk in African American patients. And so African American potential participants on the P1 study were automatically at a disadvantage in terms of their risk assessment and being determined as eligible to participate in the P1 study. Subsequently, I and my colleague, Dr. Werda McCaskill-Stevens, who you will be hearing from shortly, had the pleasure of working with the brilliant biostatistician, Dr. Mitch Gale, to modify the Gale breast cancer risk assessment model to actually make it more appropriate in its risk assessment of African American women. Other clinical trials have continued to show us that African American patients often have a worse outcome compared to white American patients on clinical trials related to differences in tumor biology. This has been seen in other adjuvant therapy trials, in studies of metastatic breast cancer. And in the studies shown all the way to the right, we are also learning more about the use of genetic African ancestry in clinical trials, where Dr. Brian Schneider has demonstrated that germline genetic ancestry is associated with a higher risk of taxane-induced neuropathy through the study of these toxicities in prospective clinical trials. The TAILOR-X study, it was a large, very powerful study looking at nearly 10,000 women with hormone receptor positive, HER2 negative, and node negative breast cancer. And it was designed to evaluate the 21 gene recurrence score for women with certain categories of risk to determine if we could de-escalate chemotherapy treatments. And we learned some powerful messages that were very provocative with regard to tumor biology in African American women. When it came to the participants with the intermediate risk scores, the African Americans had a higher risk of recurrence and a higher risk of death, suggesting, again, that there's something inherently more aggressive about the tumor biology of breast cancers, even in hormone receptor positive disease among African American patients. In the interest of time, I'm going to skip over some of these slides. So we do need to implement better ways of conducting clinical trials and better ways of offering clinical trials so that we can capture more information to learn about disparities. And we are making progress. In December of 2020, the Clinical Treatment Act was passed as a bipartisan legislation that mandated Medicaid coverage for routine costs associated with clinical trials, such as lab tests and clinical visits. And we are seeing clinical trialists getting more savvy in the design of clinical trials. And Brian Schneider, who I mentioned previously, now has a trial actively accruing, which is accruing specifically for African American breast cancer patients to study peripheral neuropathy in different types of taxane therapy. The FDA has put together a very nice guideline package of tips to try to help us in improving our accrual of diverse patients onto clinical trials. And I've summarized some of those strategies on this slide: broadening eligibility criteria, addressing the sample size so that we oversample patients that have a higher burden of disease, limiting the inconvenience of trial participation, being more inclusive by involving advocates and community-based organizations, considering geography and where those clinical trials are available for accruing, holding recruitment events, using social media, making it easier for patients to participate by helping them to get their medical records and utilizing electronic informed consent. Whenever I talk about disparities related to any type of cancer outcomes, I always close by quoting these three survival rates of 60%, 43%, and 20%, which have nothing to do with cancer outcomes. But these are the survival rates for the first class, second class, and third class cabin passengers of the Titanic. And it simply underscores very tragically that outcome and the likelihood of surviving any threat is always going to be related to access, number one. And just as the third class cabin passengers of the Titanic did not have access to the lifeboats, it remains true that our communities of color, especially African Americans, we do not have equitable access to healthcare, to cancer care, and we still do not have equitable access to cancer clinical trials. And as stated by the Reverend Dr. Martin Luther King Jr., of all the forms of inequality, injustice in health is the most shocking and inhumane. So thank you all very much for your time and attention.
Thank you, Dr. Newman. We truly appreciate your passion and learning about some of the latest clinical trials and the challenges that are involved and the hope cancer patients can have for treatment in the future.